And we've got Bill C., who we'll be showing some videos of throughout the session tonight.
The little blue pill started about 15 years ago when I was having a crisis at home and I was having trouble getting any sleep at all. So our family doctor recommended Zopicone, and that's where it started. And it hasn't completely ended yet. Well, if it hadn't been for Zopicone, I might not have been here doing this today.
So it helped you through that crisis point.
No question, it was a big help to that. I never dreamed there was anything like that out on the market that could do it. I've gone through a couple of sleepless nights, and the family doctor came to the house, wanted to know what he could do, and I said, if you can get me some sleep, and he said, I can put you to sleep. Well, he certainly did for a couple of days. Terrible taste in your mouth. You just feel like you're going to throw up or something. It's a rotten taste. I wake up in the morning and I don't remember certain things that I've done at night. If you mention it, I could probably give you all the details about it. But if you hadn't mentioned it, it would have been gone. I don't know anything about it. So that's not a good feeling. I was in a fog the next day. It was just surreal.
I think this experience is quite common for a lot of our patients when we take the time to ask them these questions. So I'll pass it over to Charissa again.
Yeah, we had some questions in the chat box about the volume. It was quite quiet on our end. I don't know if there's a way of adjusting the volume on your end. Just, we're going to have more videos.
Is
that better?
Started about 15 years ago when I was having a crisis at home and I was having trouble getting.
Is that working? Okay.
Did that work for anyone else? Yeah, I'm assuming yes. Okay.
I'll finish playing it just for those who aren't able to hear.
Any sleep at all. So our family doctor recommended Zopicone, and that's where it started. And it hasn't completely ended yet. Well, if it hadn't been for Zopicone, I might not have been here doing this today.
So it helped you through that crisis point.
No question, it was a big help to that. I never dreamed there was anything like that out on the market that could do it. I've gone through a couple of sleepless nights, and the family doctor came to the house, wanted to know what he could do, and I said, if you could get me some sleep, and he said, I can put you to sleep. Well, he certainly did for a couple of days. Terrible taste in your mouth. You just feel like you're going to throw up or something. It's a rotten taste. I wake up in the morning and I don't remember certain things that I've done at night. If you mention it, I could probably give you all the details about it. But if you hadn't mentioned it, it would have been gone. I don't know anything about it. So that's not a good feeling. I was in a fog the next day. It was just surreal.
Great. So is that better for everyone? Excellent. Thanks, guys. So I'll pass it back to Charissa now.
Okay, so it's time for everybody to participate again. We want you to let us know when somebody comes to talk to you about sleep, what are the questions that you ask? Oh, wait, no, we're going to look at the answers first from the last one.
Oh, it's gone now. That's okay.
Mostly B. Was B the behind the knees one?
Yep.
There you go. All right. I have one cat that does that. Okay, so yeah, so this time if people can give us your questions that you ask your patients when they come in looking for a sleep aid.
And if you're comfortable just talking in person, feel free to pop yourself off mute too.
Sorry, how do you get the question to regenerate? It's still frozen on the first one.
Is it showing now as activated?
Do you have to re-enter?
You shouldn't, no.
No?
No, I was going to answer here.
I'll figure it out.
I tried this earlier with success, but if it's not working, we'll ditch it and go back to chat box and in-person chatting. There we go. Why are you seeking a sleep aid? Do you have trouble falling asleep or staying asleep? How long have you been having difficulty with sleep? Are you having problems getting or staying asleep? What have you tried? Is there anything that's going on that could be causing this? Lots of great questions.
Mm.
Perfect. So we can pop back on over here and have Charissa guide us through her answers to the question.
Okay, so these are some of the responses that we came up with ourselves. So how many hours of sleep do you get at night? How many hours do you think you need to sleep at night? There's sometimes a disconnect between how much sleep a person needs versus how much sleep a person wants. How many times do you wake up during the night? What causes you to wake up when you do? I think somebody had that question in the chat box there. How long does it take to fall asleep? Do you ever feel tired or impaired during the day? Is there a consequence to your sleeplessness? Do you sleep during the day? Adding sleep during the day can subtract sleep at night. And also get them to tell you about their bedtime routine. So some of these other causes that might be causing sleeplessness could be medical conditions, could be related to sleep apnea, restless leg syndrome, cardiovascular disease. Maybe they're having trouble breathing while they're laying back. Diabetes, depression, anxiety, and pain, all of these can cause difficulty with sleeping. And it's important to address the cause of the sleeplessness rather than just the sleeplessness. In addition, people can have problems with medications that might be causing them to have trouble sleeping. They might be taking stimulants too late in the day. Maybe they're on something like dextroamphetamine and it's a long-acting product and they're taking it too late in the day. Diuretics taken at the wrong time, getting up all night, going to the bathroom. Steroids that should be dosed in the morning being taken late at night. Lots of over-the-counter medications where it's not clear that they're not just non-drowsy, they're actually stimulating. Caffeine, nicotine, laxatives, decongestants. One other one that sometimes comes up is statin drugs. Some people find it difficult to sleep when they're taking their statin in the evening, and most of them are okay to take in the morning, so that can be another easy way to address difficulty sleeping in somebody taking a statin. So when you're talking to your patients, when you're counseling, what are your go-to non-pharmacological strategies? What do you tell them to try before trying medications? We can just get some more text messages here. Maybe it's listening to me talk. There's an answer for you guys. No technology an hour before bed. I like that. Yes, the blue light, definitely an effect for people.
And again, if you're having trouble with the technology, you can use the chat box in Zoom, or feel free to pop off mute and give us your answer.
Okay, so sleep hygiene. So these are the non-pharmacological measures to try to help with sleep. As already mentioned, no TV, tablets, or reading in bed. Basically, bed should be reserved for sleep and sex. Everything else should be outside of the bedroom. No napping during the day. Some people want to make sure that they have their exercise at least 6 hours before sleep, although for some people it's the opposite. Make sure to adjust the temperature, light, noise level to something that is conducive to sleep. I kind of refer to this as the Goldilocks theme. You know, you got to find your just right. Is it too loud? Is it too quiet? Or is it just right? Is it good to exercise before sleep, or is it better to exercise in the morning? People need to find their Goldilocks way of going about things. and obviously avoid stimulants before bed like coffee, nicotine, and alcohol. But generally speaking, just sleep hygiene alone is not enough for somebody with chronic insomnia. So step 2, not drugs.
So we're talking about CBTI, or cognitive behavioral therapy, for insomnia. So there are lots of components to this, and it can be quite complex, where we have dedicated clinics and practitioners who deal with this, but there are lots of components that we can include in our day-to-day practices. So the cognitive pieces are changing those inaccurate or unhelpful thoughts that patients are having about their sleep, as well as addressing some of the behavioral aspects. So having patients learn relaxation training, whether it be meditation, stretching, yoga, whatever works for them, even deep breathing, can be stimulus control. And like Charissa said earlier, using the bedroom only for sleep and sex, waking up and actually getting up out of bed at the same time every day. Doesn't matter if you're working or it's a weekend, only going to bed when you're sleepy. And if you're having trouble falling asleep, remove yourself from that bedroom, go to another room that's nice and cozy and do something that's relaxing, or something very repetitive, like reading the same sentence over and over and over again to help your body force yourself to sleep. So there are tons of resources out there that both patients can use and us as practitioners. So one of those is Kelty Keys, another one is Sleepwell NS, and we can send out information and links on these. We can also direct patients to their employee assistance programs if they have that available to them for counseling. And there's an online primary care practitioner tool through Queen's University that we can share the details for as well. So when we're moving on to insomnia management now, I'm curious to see what the landscape is out there now for prescribing. So if a medication is deemed appropriate, what are your drugs, your doses, your durations, and your follow-up plans that you're using? So that should be activated all for you now. And again, feel free to just pipe up as well. So Dr. Helms said on Zoom, Z drugs are okay for 1 week if need be. If using, do low dose, short terms, and taper down strategies. But for our prescribers out there and our pharmacists who are filling these prescriptions, what drugs are you seeing? Okay, trazodone. Zopiclone, low dose, 3.75 to 7.5. And when you're having these discussions, what are your follow-up plans for these patients? Mirtazapine, 3.25 at bedtime. Used to use low-dose quetiapine or amitriptyline, but not anymore. Can you speak, Dr. Helm, as to why you're not using those agents anymore? We'll see if anything else trickles in. So the point to take away here is that there is no better drug or no best drug in this situation. We always have to look at the patient. So
yeah, sorry, I was just on mute there, Sydney, but yeah, no, the quetiapine, we're just hearing more and more it's terrible. And I don't know how I got into that habit. I must have gone to some CPD thing where it was recommended, and just you get into a bad habit, which eventually you have to break. And the amitriptyline, I mean, we're seeing even with low doses, the trouble we get into with that, and the joy that people have when they get off it. So why go there? Just stop doing it.
Absolutely. Thanks for those thoughts. So when we're looking at our drugs that are out there for insomnia, we're looking at our benzodiazepine receptor agonists. Those would be things like zopiclone, S-zopiclone, and zolpidem. The only one covered by Pharmacare is zopiclone, so we'll focus mainly on that one throughout tonight. Benzodiazepine, temazepam is the only one that actually has a Health Canada approved indication, but oxazepam is also used. Antidepressants and antipsychotics, we have trazodone, quetiapine, amitriptyline, and mirtazapine, none of which are Health Canada approved for insomnia. Doxepin does have an approval for sleep maintenance, but not for sleep onset, as well as melatonin. So when we look at medications, we have to think of both the benefits and the risks. So in this situation, these are the benefits. When these drugs were studied, it was assessed the time that it helps patients fall asleep and the awake time after they've had their sleep onset and waking up throughout the night. So when you look at these numbers and put them in perspective, we're at 20, 30, maybe 40 minutes if you're lucky, benefit to extra sleep in that night, either helping patients fall asleep faster or staying asleep longer throughout the night. When we're looking at some of the dosing with our benzo, or for zopiclone specifically, 7.5 milligrams is our max dose that we should ever be using. And that's even a 5 milligram max for certain populations like older adults, renal and hepatic dysfunction, drug interactions. And again, it's the only one that's a Pharmacare benefit. Looking at the benzodiazepines, the only one that we can talk about specific dose recommendations is temazepam, because again, it's the only one that has that indication. So 15 to 30 milligrams at night, but again, that lower dose of 15 milligram for certain populations like frail patients and those over the age of 65. When we're looking at antidepressants and antipsychotics, we really don't have an idea what to do for dosing, again, because they haven't been studied. But low doses are preferable, and we should really only be using these agents when there's another indication for them, whether it be depression, psychosis, dementia, something like that. Doxepin, again, only approved for sleep maintenance. Again, we need to use low doses of this agent at 3 to 6 milligrams. Otherwise, we just wind up with more adverse effects. And doxepin is really heavily affected by food. So if people are eating at bedtime or have a big meal when they take their doxepin, that actually delays the onset of that. So it's not helping patients throughout the night. It's actually lagging and causing them more daytime effects the next day. And then finally, looking at melatonin. Low doses of this is beneficial and where we're getting the impact from this medication, not at these higher doses. So 1 to 3 milligrams preferably, up to a max of 5 or 6 milligrams a night. And then finally, we're all aware of these adverse effects and how for the most part, they outweigh the risk of any of the benefits that come along with these medications. So for our Z drugs and our benzodiazepines, we're looking at falls, fractures, next day impairments, complex sleep behaviors like sleepwalking and sleep driving, confusion, hallucinations, and even like we saw in the video, amnesia and forgetfulness during the night. It's noted that patients shouldn't operate vehicles for at least 12 hours after taking these medications. And even for the benzodiazepines, this hasn't been studied specifically, and they've got longer half-lives than some of the BZRAs, so it's at least 12 hours, if not longer, that patients are actually impaired. Looking at our antidepressants with trazodone, orthostatic hypotension, anticholinergic issues, priapism, quetiapine, we've got sleep apnea, EPS, metabolic concerns, amitriptyline and mirtazapine, again, anticholinergic, weight gain, orthostatic hypotension. These are just messy drugs, and if we don't have to use them, even better when we have things like CBTI and sleep hygiene to use. Doxepin has anticholinergic effects, and again, that daytime impairment's not studied, so we really don't know how that's affecting people the next day, as well as melatonin, daytime drowsiness, headaches, fatigue. Not fun drugs if we don't need patients to take them for the little bit of benefit that they're getting. And one thing that we have to keep in mind is even though we're getting increased sleep quantity by number of minutes a night, that doesn't necessarily equal more restful or more quality sleep. It's just the time of sleep. Again, we want to minimize that dosing. Anything above this, we're just getting more side effects and more impairment the next day without any added benefits. And if a medication is going to work, it's going to work quite quickly. You should know within a couple of days. So we should really have short-term follow-up with these patients. And looking at chronic sedative use, our numbers needed to treat are 13, and numbers needed to harm are 6. So we're actually harming twice as many patients as we're helping with these medications. So when we're considering deprescribing, how do you approach your patients who have been on these agents for years, and what do you ask them about their sleep? And I'll just note, Mark's put a good comment in here, Zopiclone's only covered with special authority. So that's something to keep in mind when we're looking at options for agents. Do you still feel these medications are helping you still? Do you find it helpful? Are you feeling rested? How many years have you been on this medication for? Or how often and regularly are you taking your sleep medications? Great questions. We really need to find out how they're taking them and if they feel that they're working. Again, I'll leave that going in the background and feel free to type in some questions as we move on. We can always come back and revisit these. So we have to think about those cognitive distortions, that patients have a lot of beliefs surrounding their sleep. So some will be quite exaggerated and say, I never sleep, every night is the same misery. A lot of patients catastrophize. They say, if I can't fix my sleep, I'm going to lose my job, I'll fail, I'll die. Helplessness. I'll never be able to fix my sleep. It's completely out of my control. Some of our patients are fortune tellers by saying, I know it's going to take me at least 3 hours to fall asleep. It's not going to be helpful at all. And some people have unrealistic expectations. They say, I should be able to sleep at least 8 hours, just like everybody else. Some other people would say when we talk about stopping these medications, I can't stop my pills. And like a lot of the questions you guys said, well, are they helping you? How do you feel that they're helping you? And opening up those discussions. If I don't sleep, I can't function. So ask them about what those catastrophes were. How is it affecting them the next day by their lack of sleep? They may say, I've already tried all this stuff. Well, what specifically have you tried? Has any of it helped even a little bit? And we can look at changing that plan a little bit. Or they say, when we're talking about sleep restriction and minimizing time in bed, they may say that I can't stay up that long. And people would say, or we could say back to them, well, let's try it. The worst thing that's going to happen is you're going to fall asleep. So that seems like a win-win. So when we're considering deprescribing, we really have to talk about that cognitive dissonance. That's when the mental stress or discomfort experienced by an individual who holds two or more contradictory beliefs at the same time. So when we're talking about medications and sleep medications specifically, a patient may think that I thought this medication helped me, but you're telling this medication could be harming me. And this can make patients quite anxious. It can make them quite scared and even confused. So that's where we need to help them through this process. So looking at a trial that was done in Canada not that long ago, it's the Empower trial. It was 30 community pharmacies with just over 300 participants. They were all older adults between the ages of 65 and 95, and they were long-term benzodiazepine users of at least 10 years. So the intervention that was done is patients were mailed an evidence-based brochure comparing the benefits and harms of benzodiazepines and sedative hypnotics. So these are a couple screenshots from that document. It's a pretty good 12 to 15 page document that talks about the risks of them, some did you knows, a quiz to see if these patients would be impacted by this, as well as a suggested taper tool, encouraging them to reach out to their pharmacist or their physician or their nurse to talk about the options to come off of these medications. So what was found after a 6-month follow-up with 86% retention was in the intervention group, 62% of those patients actually started a discussion with their physician or with their pharmacist about stopping these medications. When we looked at those who discontinued, 27% in the intervention group were able to stop their medications, where only 5% in the comparator group did. And looking at dose reductions or those that were still in the process of a taper, 11% of them in the intervention group were successfully able to do that. And again, only 6% in the comparator group. So this is a great way to engage patients and have them take responsibility and have them involved in their own care. And one other important finding that I found is 98% of patients were actually appreciative of receiving this information about medication risks. So again, another great opportunity for us to engage those patients and make sure that they're well informed about the medications that they're taking. So at this point, a little bit of humor to get us through, and I'll pass it over to Charissa again.
I just see we have a question in the chat box here from Dr. Hellquist. She has lots of patients in the opioid agonist clinic who come in either on illicit or prescribed benzos or Z drugs, tapering them off, but many are anxious and going through withdrawal. So she gives trazodone or quetiapine. Has anybody had any experience in that here? I'm not sure that I have to answer that, but would anybody like to tackle that?
We can always save it for the end too when we've got some more discussion open, but we'll get through the content and definitely come back.
Okay, sounds good. All right, so we're just going to do a quick case study here. This is a patient of mine, 84-year-old female, just routine follow-up for refills in community pharmacy, and wanted to do a medication review. She had a history of osteoarthritis. She'd had a motor vehicle accident about 1.5 years earlier that caused her some pain, lingering pain in her shoulder and back. She had a bunch of drug allergies, including aspirin, celecoxib, and morphine. So pain management for the motor vehicle accident problems was difficult. And she had been using Zopiclone fairly regularly, not every night, but every 2 to 3 days for about 2 years' time. So these were the medications that she was on. She was on some medications for hypertension and heart failure, amlodipine, carvedilol, ramipril. She was on atorvastatin. She had asthma and was on a couple of inhalers. She had been put on gabapentin after the accident, 100 milligrams in the morning, 200 milligrams at night. She's diabetic. We have the sleep aid, and then she had a couple of other supplements that she was taking. She was not taking acetaminophen on a regular basis, and what we came up with, we talked about using Zopiclone, and she admitted that she was finding that it was really making her feel groggy the next day, and that's why she was only taking it every 2 to 3 nights. She used it because she felt like she had to get a good night's sleep, but it made her feel worse the next day. So we talked about not doing that and seeing how things worked out, and she managed to stay off of it entirely. And it was one of those situations where she knew that it wasn't doing good things for her, but still thought that it was going to help by helping her to sleep, but she didn't find much of a difference by stopping it. And I think that taking the Tylenol a bit more regularly to help with the pain, which was likely the cause of her waking up in the middle of the night, helped a fair amount.
So moving on into the tapering section, we just wanted to move on to Bill C experience here. And I'm just trying to move my bar so I can make sure the volume's up for you guys.
It was suggested to me by a pharmacist that maybe we should look at reducing.
Come on, guys.
I thought that was great. Well, the first night I didn't get a real good sleep, but after that it was good until I had to take the yard and do some things, and I knew I was going to be tired that night, so I go back to one full pill that night and get a good night's sleep. Right now I'm taking half a pill.
And how do you feel the next morning?
Much more awake, more with it.
Did anybody hear any cognitive dissonance in there? Anything that stuck out to you as a little bit odd?
It was pretty quiet again.
I can.
I missed it.
I can share them out with people after. But he said at one point that he had cut it down to half a tablet. He was feeling quite a bit better. And then one day he had to go out and work in the yard quite a bit. And he knew he was going to be tired out. So he took one pill that night to ensure that he would get a good sleep. And that's going back to that thought that patients are really attached to that these medications help them. So it's all about changing those thoughts and changing that relationship with the medication.
It was suggested.
Okay, so some strategies for tapering. So these are recommendations only. There's no proven best schedule. It's going to be whatever works for your patient. And so these are just some ideas. So you start by cutting the dose in half a couple of times a week for the first couple of weeks. And then in the second 2 weeks, you cut back the dose to half. Sorry, I'm losing my English. Let me try this again. Cut down to half of a dose 4 or 5 times a week. And then by weeks 5 and 6, you're half a dose across the board. And then just kind of taper as tolerated by the patient. You got to continue to monitor for things like rebound insomnia, tremor or anxiety. Rarely you might see hallucinations, seizures, and delirium. And if those things are happening, then the taper needs to be slowed down. I think the key thing to know is that some people will go faster than others. I've seen people on Zopiclone be off of it within 4 weeks and feeling great, and other people will take months. And it depends a lot on their symptoms. A couple of tricks to think about is the availability of drugs. So temazepam is the one benzo that's indicated for sleep, but if somebody's on temazepam, it's a capsule. So how do you cut that down to half of a dose if they're on 15 milligrams? Well, switch them to something that is a tablet. Oxazepam is available as a tablet. It can be cut into quarters if need be. You can also, if you're looking at Zopiclone, you can use the 7.5 and the 5 milligram tablets to do a slow taper. So say you're at 7.5 milligrams, you can drop to 5, and then half of the 7.5 to get to 3.75. And then half of the 5 to get to 2.5. So you can make that taper as slow or as fast as you want. Yeah. So in terms of how quick that taper should be, these are rules of thumb, not necessarily the be all end all. If a person's only been taking these medications for 6 to 8 weeks or less, you might not need to taper at all. If they've been on a really high dose, or if they're on really short or intermediate half-life, such as alprazolam or triazolam, which they shouldn't have been using for sleep anyway, but then you may have to do a taper off of those because there will be a higher rate of withdrawals because of the short half-life. If they've been on it for 8 weeks to 6 months, then you might be able to taper over 2 to 3 weeks, which is not that bad. 6 months to a year, you're looking at 4 to 8 weeks. If it's been more than a year, then you're looking at months, 2 to 4 months. But you can consider to go slower in the latter half of the taper. You might be able to taper quicker at the higher end of the dose and then slow things down at the end. Make sure that the patient is aware that tapering reduces but doesn't completely eliminate withdrawal symptoms. And advise patients to avoid alcohol and stimulants during the taper, which would make it more difficult to sleep if they're using stimulants, and alcohol complicates things as well. So, of course, we're talking about the senior population. So what are some special considerations for people over 65? You may have to consider an even slower taper because they are going to be at higher risk for delirium during those withdrawal phases. Diazepam is an option because it has a very long half-life. It's less likely to cause delirium in the elderly. It's obviously not a great choice for insomnia, but it might be a good choice for tapering off of something. If somebody has hepatic insufficiency, oxazepam or lorazepam are the better options to use. But the big thing to think about is that you have to listen to the patient to determine the right schedule. They have to be on board, they have to want to do it, and they have to feel comfortable and confident to do it. So helping them or allowing them to be in the driver's seat in terms of selecting a tapering schedule will help them to be more successful. So the thing you've got to know at the beginning is, what is the goal? So we have the 3 responses. Is it discontinuation? Is it just decreasing the dose? Is it reducing to intermittent use? Maybe we only want them to use these things once or twice a week. Or is it some other goal? If we can get some responses. That.
Charissa, just a comment. You're quite right. It depends on the patient, and some will be able to go faster than others. But you're trying to get the patient on side. You're trying to win their confidence. And I just look at your suggested taper there, and I'm initially cutting by half, etc. I just concerned that we give people a bit of a bumpy ride if we do that, and if early on we give them a bumpy ride, we might lose their confidence. And so maybe not 50%, but 25% or even 12. I like telling people, if we cut you back by 12.5%, so that's we're cutting tablets into eighths, etc. But your body is hardly going to notice this, whereas I think people will hear cutting into half. Some of them are going to get a fright and think, oh my goodness, that's a lot early on. So my philosophy has just been in it for the long haul. If it takes a year, that's fine. If a year from now you're off, that's just fine. Let's not rush anything. So just a little bit slower than your proposal there. That's all I'm saying.
And I don't disagree. I mean, cutting the tablet in half at the beginning was only twice a week, so
yeah.
Cutting it by an eighth is kind of about equivalent. So to a certain point, it's about convenience to the patient and their ability to do what needs to be done. And if they have the dexterity or the option to be able to cut it into eighths or quarters, then I think that's a fantastic way to go. Well, one thing I forgot to bring up is it's sometimes good to get a compounding pharmacy on board, because they can actually compound unique doses, just crush the tablets up and put them into a capsule form. So that's another thing that can be helpful.
Yeah, so looking at the poll here, either one person or everybody said intermittent use. And I see Christy noted in here that she said D, other, which was patient comfort, improvement of quality of life, which are excellent answers. But our answer is actually all of these can be the correct answer, depending on your patient, that there's no one size fits all when we're doing these tapers and what the end game goal is with these medications. And I think I figured out the issue with the video always seems to be my headset. So I've taken that out, and we'll see if we can hear the last question or the last video a little bit better. But we'll send out this information as well. Deprescribing.org has great algorithms to help with deprescribing, not only benzodiazepines and Z drugs, but all kinds of things across the board. So we can definitely send the resources out for that. They just go through the background. Why is the patient taking it? Processes for recommending deprescribing in certain populations, monitoring programs, as well as the availability of some of the drugs and how to engage patients, talking about that sleep hygiene and the CBT. Lots of great resources there that we can definitely send your way. So in closing, just some options on how to change your practice. So there are lots of things that you can take away from tonight's session, one of which would be just to start those deprescribing conversations with patients. One thing that I like to use in my practice is say, hey, look, these medications are dangerous. We've talked about that in the long term, but if we were looking at giving you medications for insomnia today, we would never pick this medication for such a long duration. So I realize that you may not be ready to start this taper today, but it's something I'd like you to think about, and there will come a time that we're going to have to slowly pull away this medication, and I just hope that that can be before it causes you significant harm. You can ask about overnight and next day effects of these agents. Just pick a few parts of sleep hygiene or cognitive behavioral therapy that you can regularly discuss with your patients. Refer patients to some of the websites that we talked to tonight. There are tons of apps out there, books or employee assistance programs. I've actually kind of picked out Jody a little bit, who is our practice support coach here in Dawson, but our physicians and other communities as well could get in touch with their practice support coach for helping to identify these patients who are on these types of chronic medications, and using something like the Empower brochure to send out to them to start some of these conversations and get the patients empowered in their own care. And then finally connecting with Rochelle Miller, who's on the line tonight, who's a provincial academic detailing pharmacist. She has a great new insomnia topic that was just out, and myself and Charissa and Dr. Helm were able to do that last week. And it's a great resource and goes into lots more information about the medication. So I would definitely encourage you to reach out with her to set up a detailing session.
It has to be used with caution you've got quite a responsibility in your hands to provide patients with reactions it could have on their body, but it still has its place for extreme cases.
Absolutely. So that short-term use and close follow-up to make sure that people tolerate it well.
Exactly. I never had any follow-up. It's just, here's another prescription for another 3 months. It has to be.
So we'd like to thank you for coming tonight and ask if there are any questions. But before we close, for those of you who don't know or haven't figured it out during the session, Bill C. is actually my grandfather. And it's actually been quite amazing to see him come alive again, even if it was only virtually over the last couple of months by tapering these medications. So it really does have an impact on patients' quality of life and their relationships and things like that. So really hoping that you can take a message from tonight and incorporate that in your own practice for your own patients. So thank you.
Sydney, it's Dirk Kotze here. Can you hear me?
Yes, I can.
Great. I got a couple of just sort of questions and comments. The one is, and I'm sorry I missed the beginning of the talk, but I think there's, for me, a big difference between someone who's got a history of chronic insomnia, you know, even when things have been going well in their life and they've, you know, that nothing has sort of derailed them, and someone who maybe comes in the setting of a major psychiatric disorder that's acutely disturbed their sleep. And I think they definitely, you know, I see people that without a sleep aid, they're just not going to sleep, and not sleeping is a risk factor for a number of you know, I think serious medical health conditions. So just, you know, I think just taking that history as well and trying to sort of find out what you're dealing with, and someone who's got a more acute onset of insomnia are definitely more the people that I would really try and get off their sleep aid. I think for me, one of the pearls of the talk is really getting your patient to buy into deprescribing. And one of the most anxiety provoking things that I see in my practice is, you know, if you tell someone, I'm going to take you off your benzo or your sleep aid, they get very distressed. And I find that, you know, I mean, I think number one, providing them with some evidence that this stuff is actually doing harm. And I think, you know, it takes 12 patients to treat over 6 to harm. I think that's a great statistic, just a short and sweet to offer people. But I always say to people, you know what, you and I are going to do this together all the way, really slowly, your comfort level. And if it doesn't work out, we can always go back to what we're doing. And I think that might be a little bit of a cop-out, and, you know, because ultimately you don't really want that for them, but at least they're reassured that if it does go belly up and nothing else works, that they're not going to be left high and dry. Because I see a lot of patients who say, you know, the doctor just cut me down, and I've just been miserable since then. I haven't slept, or, you know, I'm so anxious, I'm busting out of my skin. So just those comments. Thank you.
Absolutely. It's definitely a team process with the patient and all healthcare providers together, and a close follow-up process. We can't just pull that away completely. It's regular follow-up, whether it be with a community pharmacist, the physician, a team member at the health unit, so that we can check in with the patient, make sure they're doing okay, and definitely adjust that tapering schedule to their comfort level.
Yeah, and further to that, I like to tell the story of a patient that I've been seeing for years who's been on clonazepam regularly, not for sleep, and so we didn't discuss it in this session. But I talked to her 3 years ago about whether she would be considering coming off of clonazepam at some point. She'd been on it for 20 some odd years, and she wasn't even entertaining the idea at that point. And then talked to her again a year later, non-judgmental, just, oh, you know, are you ready to maybe cut down your dose? No, not yet. And then the next time I didn't have to bring it up at all. She said, yeah, I think this is not good for me, and I think I need to start cutting off. What can I do? And so it has to be on their schedule. They have to be ready for it. And when they are, they will come to us if we treat them with respect and kind of keep that line of communication open.
Another comment we've heard from Dr. Helkvist and from Dr. Kotze about some of the real challenges. And I think that's real life. You know, we know what the ideal is. We know that in the majority of cases, we'll be able to achieve that. But there are going to be these really challenging cases where you know what you're doing is not maybe ideal, but you just not doing anything is even worse. So you get sucked into this, and you know, as long as you're not getting sucked in all the time, it's probably okay. And as long as we have the insight to know what we're doing is not optimal, but it's the best we can do under the circumstances. So I think that's reality. The other one is, you know, we see quite a bit of gabapentin, which was mentioned, Charissa, in your the medication list of that one patient of yours. But specialists recommending, you know, the patients on gabapentin, well, let's give them the whole dose in the evening because it's going to help them sleep. We had a great pad talk from Rochelle pointing out that gabapentin works in about 1 in 8 cases. So in 7 out of 8, it doesn't work, but patients stay on this anyway. And oftentimes it seems they're using it more to help them sleep than for any perceived benefit with their neurological symptoms. So maybe something else that is suboptimal.
Yes.
Can I ask the pharmacist we have online? I'll tell you why my patients love me when they need to split a tablet that's you know, difficult to split. I tell them just to crush it, cut it with a credit card, and snort a line. But in seriousness, if you have a, let's say, a ZOP and you crush it up and you cut it into let's say 8 more or less equal portions, and you use 7 of those. And I do say to my patients, and you must please tell me if this is totally the wrong thing to do. I say, take those 7 out of 8 portions, put them in a little bit of juice or in a little bit of yogurt, because we all know medicine always tastes awful. And you're taking 7/8 of that thing, but you know, because they can't really break it. And then you go to, you know, 3/4, and so on and so forth. Is that a kind of a reasonable thing to do? And I've even suggested that with capsules, as long as they're not an extended release, you could, you know, you could do that kind of thing.
Yeah, I think it is reasonable as long as they're cutting it or crushing it immediately before they're using it. I don't know that you could say that the drug was going to maintain its usefulness in that, like in essentially a crushed form for very long, but I can't see it being a problem.
I mean, you're not going to have any evidence on this, and you're not going to have any pharmacist to endorse it. But the biggest thing is, we know if we're tapering somebody off of it, if you're giving them 1/8 of a pill, it's less than the 1 pill that they were on. Yeah. So I think we're all just going to plug our ears and say la la la.
Yeah.
There are some formulations that the coating is actually protective, so it has to be used for actual safety, depending on where it dissolves. It could be toxic if it's not dissolved in the right area of the body, but those are some of the newer agents. But the Zopicon will taste horrible if you do that. And some patients will still say that, you know, after they're on it for a while, like they're throwing their milk out in the mornings because of that really strange taste. And, you know, anecdotally, like, don't drink milk right in the morning, or use that brown Listerine because it masks it so awfully that you can at least tolerate that, and then realize that it's not your food that's rotten. But yeah, we're going to plug our ears on some of that.
That's fair enough. I have heard that acidic things can actually reduce that metallic taste that people have in their mouth from Zopiclone, like sour sweets or orange juice. I haven't, you know, I don't have my own experience, but people have reported that. But I don't think we should tell them that if we're trying to get them off the drugs. So.
And one thing you can do with Zopiclone is it comes in both 7.5 and 5s. So you can go from 7.5 to 5 to 3.75 to 2.5, and maybe even quarter it to even smaller. So there are some ways around that.
or get it compounded. It's another option. It's more expensive, but you want it to be precise.
Yeah, I did open the last poll just to see if anybody has any big takeaways for tonight or any exciting thoughts on how to integrate any of this information into their practice. But if you just want to pipe up or if you have any other questions, feel free. We've got a few minutes left in the session.
This is really helpful. This is really good. Good job.
Thanks. You inspired a lot of it with your pad talk. So I encourage everybody else to make an appointment with Rochelle. I'm just looking back, Dr. Helquist, you had that question earlier on about taking off benzos or Z drugs and going to trazodone or occasionally quetiapine. I think we always talk about switching between benzos to other agents to help with that taper process. And I mean, you could switch drugs as long as the patient's aware that this is kind of a short term to help curb that transition, but it's not going to be a switch from one agent to another agent for the long term. It's incorporating that sleep hygiene and the CBT options to help with that insomnia.
Yeah, this is Lita Helquist. You know, this is a problem that's been something I've seen in family practice too, that a lot of these patients who have kind of poor ability to engage with CBT, maybe they're very scrambled or maybe they've had a brain injury, and those are the patients I'm finding the most challenging because a lot of them can't cope without being able to sleep, and a lot of them have trouble engaging with the therapies. So that's kind of, I'm wondering if anyone who has more experience, I'm pretty green, maybe if someone more experienced knows, has had some success, I'd really like to hear about it.
Dr. Mayer has just commented, there's a library online that has sleep-inducing music. They investigated which music induces sleep or meditative sleep, works well but requires to sign up with them. So that would fit within that realm of non-pharm options. And Charissa, were you going to say something?
Well, I was just going to say, like, I'm trying to think of a situation where we managed to get somebody off of sleep aids who was also part of the OAT therapy, but yeah, I can't think of any examples right now, or I don't really have any pearls of wisdom there, unfortunately. I apologize.
Jody, I threw you under the bus a little bit there. Do you have any comments on how you might be able to help physicians in their practice incorporate some of this patient finding and how to go about identifying these patients so that we can start to have some interaction with them?
Well, that really got me excited when you mentioned my name. Of course, I thought you were referring to the doc that's on here, but no, I would be happy to help anybody identify those types of patients within the EMR and then set up some sort of action plan to do whatever the physician kind of wants to. Take 10 patients and analyze and see what we can do. Yeah, it would be just so easy. And it gets me so excited. I'm already thinking of a report I can build within the systems to get this information out. So yeah, I would encourage anybody that would be interested in that, Christy, you included, to reach out. I can certainly help. So thanks, Sydney.
Any other final thoughts or questions before we sign off tonight?
Dirk again. Just a quick comment on Dr. Helquist's question. Without wanting to sound too cynical, you know, I think some patients who may be on the OAT program are it's likely that they are misusing their medications, including selling them, sleep aids and things, and you know, all sorts of shenanigans go on. So I think one should just, I mean, number one, try and be sure that they actually are using the drug and sort of how they're complying with it. I think depending on what your patient's doing, if you, for instance, if you're trying to reduce the any of the other treatments, I wouldn't mess around with their sleep aids at that point. It would be very much a do one thing slowly at a time. Otherwise, you're very likely to end up in a pickle, in my experience. But just that comment. Thank you.
Great. Thank you all for joining.